this is really a medical question, but let me throw it at you anyway. You think it's, you think that a parent that spends more time, more effort in those early years, more love and affection with the child is going to have a child with a higher IQ? Is there any relationship?
That's an interesting thing. I don't know that there really is a relationship between IQ, because that's sort of an artificial testing number that we give at. I think more so, you know, parents who are able to kind of give them an enriched environment and give them extra opportunities for learning may be able to support their growth more broadly. So I think they might do
better on the test that calls for IQ that way.
Supposedly those tests kind of rule out that bias, but some of the adaptive behavior that looks more like at functioning levels, I think definitely opportunities. Things that are looking at skills such as, you know, do you know how to navigate your way around your home? Do you know how to problem solve? Do you know how to be resourceful? Things like that. I think families can often play a really, really instrumental role in helping their kids develop all kinds of skills beyond just academic skills.
Okay, so let's take me in my case study with you, and I'm only one kind of impairment. I'm the low IQ. I'm 55, and somebody notices I'm a little slow in getting around, or somebody notices I'm a little, or maybe more than a little slow in school. How does that information get to you? How do you find out about that?
If I'm the parent, or if the provider?
As the government, yeah, the provider.
Okay. Hopefully, we have kids that are enrolled in preschool programs, and some of our kids that have special needs are identified, you know, during well baby visits, regular visits to the pediatrician. The pediatrician may suspect that
that'd be earlier than
there
preschool.
Would be, that would be earlier than preschool. I mean, we're looking at some screenings at 18 months, 12 months for
so the pediatrician should be able to spot this if this is, say, a low 55 IQ.
Yes, you look at verbal ability. Are they using complex words? Are they able to form sentences?
Yeah.
Those are often early indicators.
Or if you find a child who's, say, 3 years old, hasn't spoken a word yet, that'd be an indicator.
That would definitely be an indicator. And, you know, Department of Health has early intervention programs that help address those issues.
Okay, now what's your role as the coordinator? Do you get involved? Somebody says, a pediatrician who's doing one of those well baby checks, he says, this isn't working right. I better get some help for this family. Does he call you up? How does that get to your desk?
That's a good question. We have, you know, we do have resources within Department of Health, specifically for the program we're talking about. We're looking at mental health services. So we will be looking at kids that have behavioral problems, social,
we're going to go to that
emotional
next.
Pieces as well.
So are you concerned? Are you concerned? Are you involved in the intellectual side, that is the IQ side?
I'm personally not, and I think that kids that get referred to CAM-HD probably, you know, have providers that have already been working with them. They may have families that call and ask about services as well. We do sometimes get phone calls from providers in the community that are looking to see what our supports Department of Health might be able to offer beyond community-based services.
Okay, it sounds like that. I'm just trying to put this together. It sounds like you'd be more likely to get involved if there's a child with behavioral problem where he was acting out, or she was acting out at a young age, maybe in preschool, and it wasn't working for that child in the preschool because he was becoming a troublemaker in the context of the class, whatever. Okay, so the teacher notices that. Maybe you also have some information about this process from the pediatrician or the doctor, and now they don't know what to do. They don't know what to do. They say, well, we don't have a way here. We're going to contact the State Department of Health. Am I right? Does this come to you on your desk?
Sometimes that does happen. I think the typical age for most referrals to CAMDU is like 14, though.
Oh.
So sometimes we're talking about youth that have had ongoing problems, and
For a
then as
long
they hit
time.
adolescence, things get a lot harder for
Sure,
families.
sure, it's a
or they
harder
get
time in life, yeah.
So it may be that you could look back historically and see that perhaps these kids might have had problems when they were earlier, but as time goes by, either interventions haven't worked, or things that classroom teachers may have tried haven't worked, or that families have tried. So as some kids are going to need more specialized care and approaches. So I think that's more when the Department of Health gets involved, as the typical supports haven't made the difference, or
Yeah.
the youth continues to have problems, or it expands in other areas. So those are the more higher need
You mean like they
kids that are
become
getting.
juvenile delinquents?
Some of that might be,
Yeah.
issues that families might be dealing with.
And the families
Could
can't
be behavior
really.
in school or at home.
Disruptive.
Could be that. It could be that they've been trying different things and they really need more specialized support, or more, really therapeutic interventions from specially trained providers that
Okay.
understand about mental
So this
health.
is a young teenager
Could be.
in puberty
Could be.
who has trouble in a world that may not be so tolerant as it was if he had trouble at the age of 6 or 7 or 8. And now it's become real, and the earlier efforts haven't. Well, I guess I would put this to you. If there were earlier efforts, assuming that, I have a feeling in a lot of cases there aren't earlier efforts, but if there were earlier efforts, does that tend to ameliorate the long-term problem, or is it just an intervention on a short-term basis, and that there's no real relief because of that intervention at the age of 6, 7, and 8? I mean, could you sort of head this off somehow, or is it going to happen anyway?
I think that the idea is that the programs within Department of Health are looking at providing. We have like intensive services, with the idea that yes, you're going to intervene. You're going to really look at providing some quality therapeutic interventions at a level that may be beyond what youth could access through their private insurance, or because we're looking frequently at home and community settings, schools aren't able to provide in those settings. And so they're kind of specialized programs within Department of Health, with the idea that providing an intensive level will then help change a lot of the behaviors, do interventions, then give families skills and tools to work with their kid at home, so that you really can make a difference.
So you do actually have success in
definitely.
these programs.
Definitely.
Now, is it the kind of success that puts the kid on track again, or puts the kid on track so that he's not going to have these problems, emotional problems, mental health problems, going forward, or is it only a temporary solution?
I think it's going to vary from child to child and from the family situation to the family situation as well. Those are really key pieces. Individually, you're going to have different responses. But I think overall, the idea would be that you really are doing some interventions that make a difference, that help the youth. For our population, also we're talking about youth have got intellectual disabilities, and so
they come together.
They come together, and so sometimes that progress might be a little slower. It might take a little more time. We aren't really, we're not going to be able to make a difference as far as their cognitive skills. So what we're really doing is helping them, reduce some of those behaviors that might make it difficult for the families to keep them at home. That might make it difficult for them to be successful in the community or in the environment.
Where people resent it, and maybe take it out on him.
Or might even really misunderstand some of the behaviors. Or really attribute them to other things that maybe they're concerned about them becoming aggressive, and perhaps safety issues might come up. So those are really important things for us as a community as well as our families.
Well, you're anticipating my later questions.
Okay. Good, we're thinking forward here. Okay.
So before we take our break, which we will in a minute, I just want to get the point of contact established with you. So I'm a mother. And I find that my kid is 12 or 13 years old, in puberty, in junior high school or high school, early high school. Problems in school, problems in homework, problems around the house. Something's not right. So I figure and I don't have options, or at least I perceive I don't have options. So how do I get connected with you as the collaboration facilitator?
Well, we are doing outreach to the community
Yeah.
and also to the school systems,
Yeah.
to some parent groups, parent groups for kids with special needs, so that we want to have some visibility there. Because we're a Department of Health program, we do work with the family guidance centers, which are kind of, they have their own
So
structure.
you're going to put me together with the resources that are available?
That's one of the things we could do.
And you're going to decide which one of these resources, or social tools, call them, is going to be most likely to have a positive effect on my child.
And I think talking to the families, we kind of get it. We want to look at, what are the needs that they're looking, and then we could look at them, what kind of possible resources. It might be within the Department of Health. It might be a referral to another state agency. It might be connecting them with a parent support person.
It's triage.
It could really be a different types of services.
So you have any number of possibilities, and you're going to try to channel me in the right direction.
And hopefully there's a fit, and hopefully the eligibility works, because different programs do have different.
Oh, right. We're talking about money now. I love talking about money.
Okay.
But we're going to take a short break and come back when we talk about money. Okay, you ready? You prepared for that?
We'll give it a shot.
Okay, Sue Emely. She's the collaboration facilitator for the Child and Adolescent Mental Health Division of the Department of Health. And we're talking to her about just exactly how that works. And we're going to talk about Project Laulima when we come back. You'll see. We'll be right back.
Aloha, I'm Kili'i Akina, president of the Grassroot Institute and host on Ehana Kako, a weekly program on the ThinkTech Hawaii broadcast network. Ehana Kako means let's work together. Think of the sad alternative, let's not work together. Here in Hawaii, with all of our diversity and the richness of the people, it's important for us to come together around issues on the basis of what's right and what's good and what's going to serve the common good. And that's what we try to do at Ehana Kako. Every week we interview movers and shakers, people in government, business, and other sectors of society to talk about how to create together a better government, economy, a better world here in Hawaii that can bless the rest of the world. I thank you for your attention to ThinkTech Hawaii, and we look forward to seeing you every Monday, 2 to 3 p.m. on the ThinkTech Hawaii Broadcast Network. We're Ehana Kako, and we wish you well. Aloha.
Piece, so it's
you're
pretty
grant
specific.
funded.
Yeah, it's pretty specific.
A lot of coordinators are grant. We're back. In case I didn't mention it, we're back. This is Susan Emely, and she's the facilitator coordinator person for child and adolescent mental health services at the State Department of Health. And so I wanted to get a sort of kind of a schematic of where it works, and I think it's very interesting. You're a grant-funded facilitator coordinator position, which I take it is not forever.
True. So Project Laulima is funded by the
That's your
federal,
project.
That's our project.
That's what wraps around what you do.
And I have one of the positions. So we have a project director. We have my position. We also have a cultural specialist. We have system spanners that are positions that are designed to work with different agencies as well. So we have a small staff, and we're sort of in the middle of our implementation phase of our grant. We started off with a strategic planning grant, and we're hoping to have another 2 years of our grant, and then be looking at how do we sustain our activities once the grant
So when you
ends.
have a grant like that, you have to report back to the granting agency?
I believe that is on the agenda,
Okay.
yes.
And are you
We
part
do
of that, or is it
update.
the
Our project director really
project director? Because
handles that.
he's like the principal investigator for
Yeah,
the grant.
well, along with Dr. Michaels. So
He
Dr.
supervises.
Michaels is the principal investigator for the grant, and he's the head honcho over at Child and Adolescent Mental Health Division. So our grant's a small component, and actually it's one of 2 grants that's currently
So when you have a
happening.
grant like that, I mean, is it, do you see this effort as for the life of the grant? I mean, maybe extended, maybe renewed, but see it for the life of the grant, or is it part of the ongoing, mental health system for the state? Tell me where it
So-
fits. Is permanent material, permanent infrastructure, or is it we're just testing a few things here and we want to see what things are like out there so we can, do adaptive changes?
So actually, we have two pieces that kind of answer part of that question. One is that it's a system of care expansion grant, which is another mouthful of words. So the concept is, looking at what current, in our strategic planning year, we looked at what exists, what are the services specifically for youth with intellectual and developmental disabilities and mental health needs, and what are the needs for this population and what isn't being adequately addressed in our current state systems. And so there was a lot of work to really look at what are different state agencies providing, and what are the things that need to happen to really help bridge some of those gaps in services for this youth. And so that's one of the reasons the Project Laulima came into being, was to help be an effort to bridge some of the gaps, and also to establish some protocols and some procedures and services that will live on after the grant ends. And I know sustainability, and especially for services, those are always important questions for families about, when they're looking at
It sounds like, at
services
least
for their
in part,
kids.
this is an attempt, and you're not the only one who's come and talked to me about this kind of position, coordinator, facilitator position, in the State Department of Health and otherwise. I guess you start out with, let's identify our resources, let's identify our constituency, our beneficiaries, and let's see if we're really connecting with them, and let's be the hub of the wheel, and see if we can't find a way to connect better so that our resources are being efficiently used. And then when we learn from that, we'll be writing our report to the granting agency, and maybe down the line, we'll have a change in the system so to take advantage of what we learned. Am I right about that?
That sort of happened in our first year for our strategic planning. And I think we've gone beyond that in our implementation phase. So we're actually looking at what activities can the grant support to really make changes in our system of care, and how can we work with other departments that are working with our youth. So there's been some nice networking and collaboration between different agencies. So Department of Health
Not all of which are in the Department of Health.
No.
There are
So
some
we're
agencies that are outside, but always in
Definitely.
state government, am I right?
We also work with some families that are nonprofit agencies as well.
Nonprofits in the community.
Yeah.
National or local nonprofits?
Local family agencies. So we have our youth in our population might be served by Developmental Disabilities Division, which is also Department of Health, as well as CAMD. They are typically in schools, so we have Department of Education partners that are usually quite involved with these.
They got to be
with
part
the
of this,
kids,
yeah.
right? We may have some youth who are also part of child welfare system. They may be in resource families or foster care. Sometimes some of our youth may be involved with juvenile justice if they're older youth that are getting into trouble.
The courts, of course.
So we have
The kids who
a
act out
range.
wind up in front of a judge.
We have a range of different agencies that, our population may be known to lots of different state agencies.
So
But they're
you have
kind of
to have a
complex
way to
kids.
select the agency that you bring in on a given case. I say you, I mean the whole Laulima program, right? And so you have people out there making this kind of triage. Say, here we have Joe Dokes, we have these agencies, we have the family. We're gonna put all this together. We're gonna connect the dots.
Sometimes when they come, when kids are coming into CAMD, they've already been connected with these agencies. It just may be that some services might be more targeted in one area, and the youth and the family may have needs in another area that perhaps isn't getting addressed, or because of different eligibility requirements or parameters that, agencies work within. So Department of Education, typically, they're looking at what's happening at school, and they're looking at education. Developmental Disabilities has a range of clients that they work with from birth way through later adulthood. So they may be able to provide some respite at times, or some other supports families might need, or perhaps some specific skill development. But what we were finding was missing was really tailored mental health services for kids with
What is
developmental disabilities.
tailored mental health? So what is that?
That so mental health services that might be used, different kind of therapeutic interventions that
Psychiatrist.
might be used, or
Psychologist.
therapists, you know. for
That's a
therapy
psychologist, isn't it?
within psychology and sometimes
So you might refer
psychiatry.
this young person to.
Well, CAMD provides some of those services, so it might be that if a youth and family are eligible through MedQuest or through the IEP process, they might be eligible for services from Department of Health. They might have then a care coordinator who might look at contracting with one of our providers in order to provide intensive in-home services. So we developed a therapeutic program that we're calling, I have to make sure I get this right, it's CBI's, it's Comprehensive Behavioral Intervention, which is modified specifically for youth with intellectual and developmental disabilities. So this is a whole new program that the grant is supporting, and services specifically tailored for kids with developmental disabilities who have mental health services.
But you're going to be calling upon psychiatrists and psychologists and maybe social workers in the community, yeah?
Well, actually, we have a contract with Hawaii Behavioral Health, so Department of Health is actually...
What is Hawaii Behavioral Health?
They're a provider with, they have therapists, and they also have paraprofessionals that would work with the youth at home, providing mental health services.
A clinic of mental health professionals. Yeah.
Well, they actually are not necessarily in the clinic, they are in the homes. They are going to visit.
So they do their therapy in the homes, outreach, rather than in an office with a big couch or anything like that.
Exactly.
Oh.
And we're providing these services across the state, and we have more youth enrolled on our neighbor islands than we do on Oahu. So that was one of our goals, was to really do outreach to underserved areas and communities.
Well, underserved, and I guess I would like to get into that. I mean, how big is your constituency and the number of people that you're serving at any one point in time?
So we just started this particular service a few months ago, and we currently have 23 kids, youth, that are getting direct services from us. We anticipate, the idea behind it is it's not a forever program. It's a program that with intensive services to kind of provide extra special support, with the idea that then we would be able to kind of gradually fade down a little bit. They'd be able to then go to their community providers or back to their other, if they have other mental health providers that aren't able to provide the frequency of service that a project.
Well, how frequent, when you do intervention, and I want to ask you exactly what that means, when you do intervention in the home, outreach intervention at the home, how often do you do that? I mean, it sounds pretty serious when you use the word intervention, because you got to intervene and change a set of circumstances by any means, really.
Well, I think it's, the plans are carefully thought through ahead of time. So when families get connected through the Family Guidance Center with a provider, there's already assessments have been done with recommendations made by professionals for what types of problems they think the youth might have, and how recommendations on how to support the family, what kinds of skills they might help teach the family, if it's crisis intervention or if it's just behavior modification.
They make a plan,
things.
as they should professionally.
And
so no,
the
I'm
family
an
has
intervener.
to really, is very involved in looking at.
They have to be there.
Well, and
they can't just turn their backs on this.
They're instrumental in deciding what are the targets, what are the behaviors they want to see addressed, what are the problems or the needs that they
they're in the
feel
room.
at them. They're an integral part of identifying the direction that.
So here I'm the selected professional in the program, and I'm, some insurance is going to pay for my time, and this is a case where we have determined that it requires intervention at home with the family and the child, because the child is acting out in such a way that it's a problem, and we're going to have to go there. Okay, so I go, I knock on the door, they open the door and they say, Dr. Fidell, how nice for you to come. What, what happens when I walk in?
Well, there's a lot that happens before you walk in.
Okay,
So way prior to that actually happening, the families would have already connected with the family guidance centers. And so Child and Adolescent Mental Health Division has 8 family guidance centers across the state. So they have geographic
all
areas.
islands, all islands.
Well, I believe Maui has that lovely opportunity to serve Lanai and Molokai,
Okay,
so
okay.
it may be the
Sure,
Maui
by
Family
county then,
Guidance
yeah.
Center, right? So after, when a family self-refers or may end up having another provider suggest they go to the Family Guidance Center, they really start that process of looking at, identifying what the needs are, and then also looking at, is this a child in a family who has either MedQuest insurance or an individualized education plan through the Department of Education that is saying they need specialized help.
Okay, and
So
all
there
this-
is a billing component and a reimbursement
sure.
component. So we aren't able to service all children across the state, no matter what their insurance is.
It's a limitation to the
There's-
funding.
those are specific programs that,
But
Family's
now
looking at.
I'm Dr. Fidell.
so you.
All this, introductory stuff has been done. All the file's been opened, so to speak. The financial arrangements have been made. I walk in the door. Mom and Pop are there, welcoming me. What do? I do therapy at home. I do my therapy.
You will have already met with the family to write up a care plan.
Yeah.
And would have met with a care coordinator, who's usually a social worker with Department of Health, to already have established. So that's all done. So the meetings take place prior to you walking in the door, consents and all of those
Yeah.
things. So the family has already had an opportunity to really talk about what they see as needs, and a plan has been presented to them. And then the arrangement would be, where would you like the therapist to meet with the youth? Is it going to be in a community setting, at a park, in a library?
Could be anywhere.
Depending on the
It's
kid.
just taking a
or
walk in the
home
park would
setting,
be okay.
or
At home would be okay. In the
somebody, yes.
library would be okay.
So it's very family-driven.
And the family's always there.
The family is always there, and a lot of the times.
I suppose the family's the problem.
Well, a lot of the times the work is with the family to help support the youth,
So-
because you don't pull the youth out just, and only work with parents.
Yeah.
So it's a combination, and again, it would be really individualized depending on the family's circumstances and the needs of the youth. So it's a very tailored, well thought.
I'm getting the
plan.
impression that this is not for the middle class. This is for the economically disadvantaged people in the state.
If you have MedQuest insurance, that might be the case.
That means you are economically disadvantaged. Yeah.
If you have a youth that, has services from the Department of Education under the Individuals with Disabilities Act, there's another method for writing some of those services into their educational plan that would say they need specialized service and supports. And so that's another way, which isn't looking at economic eligibility for the program. It's looking at behavioral needs, and it's looking at, we have a youth that's got a pretty high level of care identified that goes beyond what could be covered in the school plan, and needs to look at support services in the home and the community. So that's the other route.
Okay, let me take a quick break. I'm Jay Fidell. That's Sue Emely. And she's a collaboration facilitator for the Mental Health Division of the State Department of Health, specifically in child and adolescent mental health issues. And it's very interesting because, there are a lot of people out there who probably could use your services or the services that you coordinate. We'll be right back, and when we come back, we'll talk about how this affects the community in general. Why it's important that the State Department of Health have these programs and advance these protocols and reach out into the community this way. We'll be right back.
Aloha, welcome to ThinkTech Hawaii. My name is Josh Green. I'm the host of a program called Healthcare in Hawaii. I'm a physician. I work in the emergency department on the Big Island. I also serve in the state senate, which, please don't hold that against me, doesn't detract from my television program. We speak about all the big healthcare issues in the state. We get together on Tuesdays from 2 o'clock till 3 o'clock in the afternoon, and we try to talk about the most important issues in healthcare. This is a terrific venue for people to learn about healthcare. There are many programs on this station. We broadcast it later, not just on the internet, but also on OC16. Thanks for joining us. Please be informed healthcare consumers.
Okay, we're back. We're here with Susan Emely. She's the collaboration facilitator for the Department of Health on child and adolescent mental health issues. So, I want to cover some of the points that you wanted to cover and that Miley Sakamoto wanted to cover. Right. She's our what do you call it? Our godmother, Miley Sakamoto. Here's hats off to Miley. So, first of all, do the families ever pay any money for these services, or is this always provided by the government and the health plans?
Well, specifically for Project Laulima, no.
Yeah.
There aren't associated costs because the families are getting their services through the Department of Health. And I think that they also aren't any costs if youth receive services through the Department of Education. So most of our state agencies are providing services to this population.
Okay, and there was one of the things you wanted to talk about, that is the training. Training and what do you call professional development for the providers who are involved in the program. So part of the grant and the Laulima organization, if you will train or advance the training of your providers. How does that work?
So we have training that we're doing in several different ways. We wanted to provide supports to families as well. So in addition to the professional support they may be getting, we also have sponsored some conferences and opportunities for families to come to Honolulu. So some of our neighbor island families have come to attend SPIN conference and the Learning Disabilities Association conference, which actually has a traveling mini conference. They go out to the neighbor islands. So we've been involved in trying to support families that way. We also had an expert on bullying come recently, Dorothy Espelage, and that was very successful. We had about 70 different people attend to really talk about the impact of bullying and different strategies people might be able to use to support their youth. In addition, one of the things that we heard from providers was they felt that this particular group of youth who've got intellectual disabilities or developmental disabilities and mental health problems required a little bit of a different approach, that therapy needed to be more individually tailored, and activities that they might want to do with the youth might require some modifications in order to be effective. So we've contracted with the Center for Start Services, which is with the University of New Hampshire, to do a year-long web-based training.
But they come, web-based.
Web-based training.
So you get on and you do a course, a webinar or something like that.
Webinars with weekly mentoring.
And this is in training for dealing with your specific kinds of interventions and the like. It's really psychology training, though, isn't it?
Some of it is, some of it is psychology training, and we're really excited about this because in part of our system of care expansion approach, we really are opening it up to people from beyond Department of Health too. So we're looking at people who are coming from different agencies who may interact with our youth. So we're really excited about that.
Well, let me make a guess and say that in the 21st century in Hawaii, which is a state that is changing around us, in a state which used to be so simple, for the good old days, and now it's more complex and demanding in so many ways, especially for kids, I think. The work probably gets more challenging as you go forward.
I guess you could say that. I think the other piece is the opportunities are broader. And
opportunities for whom?
I think for us to work more collaboratively. So I think as challenges come up, they just really show us where where the kinks are in our systems and where perhaps we might want to rethink our policies, or we might want to
But you have
shift
to
our
do
thinking.
that. You have to improve
Yes,
it.
you do.
Because there are more kids every day who have mental health issues. Am I right?
I think that we know that stresses on families create sometimes more problems in dealing with kids who've got difficult behaviors. So families are feeling more stressed, may not feel as much support. You know,
So
we
are
have
we winning
Ohana
the
here.
battle, Susan? Are we winning the battle? You know, because this is a dynamic experience. If you look at the stats on one day and look at them again on the next day, they're not the same.
I think you have to, it depends on your philosophy. So you can be a glass half full or a glass half empty person. You know, the water is still the same amount. So a lot of it is perspective. So I think families that are stressed have a harder time managing things. You know, we know that about our own lives.
And that's what the
when
safety
we have
net is
demands.
designed to help
Yeah.
them. Not only, you know, your charity, or rather your division in the State Department of Health, but all the charities and all the social safety net organizations around the state.
Right.
And I mean, my observation is this is a moving target. And as time goes by, we have to, you know, make greater effort to deal with a greater number of people who are at risk. So the question is, and I'm kind of begging the answer.
Right.
The question is, why should the public in general, those who do not use your services, those who can either find psychological services, social services on their own nickel through their own insurance, you know, and don't require any intervention by anybody, why should they care about this particular division in the State Department of Health?
I think it's not well known what child and adolescent mental health is engaged with. And prior to my involvement, you know, would have to say that it really wasn't on my radar. So I think you're right. Many people never heard of CAMD, have no idea what those services are. I think, though, that there's some awesome work that's being done to really help some of our most struggling youth and our kids with the hardest challenges that lie ahead of them. The positive things are that, you know, we're able to help give kids skills so that they can be employed, so that they can become independent from, you know, all the things that parents want for their kids, so that we can look at having, you know, better mental health in our whole system, and that ripple effect that extends out into the families that our youth are in, the communities that they live and work in. You know, there's some really positive outcomes I think we could look at from really helping give kids opportunities that without interventions, they really might not thrive.
Yeah.
And what we want to do is to see that these kids make progress,
Yeah.
become successful,
Yeah.
and ultimately thrive and
Yeah.
do well.
And be
I
part of
think
a
that's-
society,
yes.
be part of society. And if they're not part of society, they become a burden on society. If they're not part of society, society suffers for it.
Exactly.
And so what you're doing in a larger sense is you're preventing a much worse outcome when they get dissociated and become a problem for all of us. So this is actually very important to the community,
We're
as I
looking
see
at
it.
keeping kids in their homes and with their
Yeah,
families.
and for the family, we have to preserve the family.
Exactly.
If these kids act out and are a problem for the family, that is a threat to the family unit.
It is, and it impacts on parents' employment.
Sure it
It
does,
impacts on
yeah.
their marital relationships.
So you're doing very
and
important work.
I think that the bigger picture, yes, really, you know, so why people should care is that, you know, we have homelessness is a hot topic right now in Hawaii. We know that some of our homeless people have mental health issues. So if we can really help our youth who may be struggling to develop coping skills, to develop resilience, to really have some success, to be employable, we're really helping our greater society, and we're preventing more complex problems and higher cost problems
Yes.
further down the road.
Yes.
Yeah.
We're out of time. That's Susan Emely, Collaboration Facilitator for the Department of Health Child and Adolescent Mental Health Division. Thank you so much, Susan. It was great to talk to you, learn from you
Thank you.
here on ThinkTech.
Thank you very much.
Aloha.
Aloha.